All right, let's talk about tracheal intubation. This is, without a doubt, one of the most critical skills in all of anesthesia. And you can bet it's going to be a core topic in your final exams. So think of this as your high-yield study guide. We're going to break down everything from the real basics, the why we do it, to how you manage the absolute worst-case scenario.
So here's how we're going to tackle this. We'll start with the fundamentals, then we'll walk through all the prep work and the procedure itself. After that, we dive into the really crucial stuff, the difficult airway plan. And we'll wrap up by looking at the bigger picture of safety and human factors. It's basically a mental checklist for your practice and your exams.
Okay, let's jump right in. Section 1. Why do we even intubate? Before we even think about touching the how, you have to master the why. That's what really shows you understand airway management on a deeper level.
So at its very core, what is tracheal intubation? Well, it's all about two life-sustaining functions. First, it gives you a direct, guaranteed path to get oxygen in and carbon dioxide out. And second, and this is so important, that inflated cuff on the tube acts like a shield, protecting the lungs from any stomach contents coming up.
So, when do we actually decide to intubate? For your exams, it's really helpful to think about the reasons in three main buckets. First, you've got patient factors, things like a high risk of aspiration or a patient whose consciousness is compromised. Then there are surgical factors, where the operation itself demands a secure airway, like if a patient is lying face down. And finally, you have the big emergencies, the resuscitative issues like a cardiac arrest or major facial trauma.
Moving on to Section 2, Assessment and Preparation. Now, this phase is absolutely critical. I'm going to say it. Success or failure in managing an airway is often decided long before you even pick up a laryngoscope. And here it is, the million-dollar question. This is something you're going to face every single day, and it's definitely something you need a solid answer for in your Viva. How do you look at a patient and predict that you might be in for a difficult intubation? Now check out this statistic from the Danish Anaesthesia database because it's pretty eye-opening. A whopping 93% of difficult intubations were unanticipated. This just hammers home a crucial point. You have to be prepared for difficulty with every single patient, not just the ones who scream difficult airway from the get-go.
So, what are we looking for at the bedside? Well, we're checking things like mouth opening. Do we have enough room to work? We're looking at the Malampati score, which gives us a clue about how much we can see at the back of the throat. We measure the theromental distance, that's from the chin to the Adam's apple, to help predict our view. And we're also looking for things like a beard or a large neck, which can make it tough to use a face mask. The key is, no single test is perfect, which is why we combine all of them to build a complete picture.
And here they are, the absolute workhorses of direct laryngoscopy. You've got the curved Macintosh blade up top, which is designed to sit in the little valley just in front of the epiglottis and lift it up indirectly. Then below it, you have the straight Miller blade, which is designed to go one step further and lift the epiglottis directly. Knowing which one to pick and why is a fundamental part of the skill set.
Okay, on to Section 3, the intubation procedure. We've done our homework, we've done our prep, and now it's time to get into the core technical skill.
Before you do anything else, you have to remember this. Positioning is everything. The classic sniffing the morning air position. What's the goal here? It's all about lining up the airway axes, your mouth, your throat, your larynx. The idea is to create the straightest possible line of sight right down to the vocal cords. The procedure itself, you can really break it down into 6 crucial steps. Get your positioning perfect. Preoxygenate like crazy to build up that oxygen reserve. Perform your laryngoscopy. Place the tube. Inflate the cuff. And then, the most important step of all, confirm you're in the right place.
And how do we confirm it? There is one non-negotiable. Absolute gold standard. This slogan says it all. No trace equals wrong place. If you do not see a continuous, beautiful waveform on your capnography monitor, you are not in the trachea. End of story. So, what happens when things don't go to plan? Let's get into Section 4, the difficult airway plan. This is all about managing the what if, and trust me, being able to talk through this plan is absolutely critical for your exams. So you've done everything right, but you just can't get the tube in. You've hit that dreaded, unanticipated, difficult airway. The clock is ticking. What do? This is the moment where you need to have the Difficult Airway Society guidelines just hardwired into your brain. And here's the crucial point to understand. It's about a fundamental shift in strategy. Plan A, that's your best shot at intubation. But the second that fails, you have to mentally abandon the goal of intubation. Plans B, C, and D are all about one thing, and one thing only, maintaining oxygenation. whether that's with a supraglottic airway, a simple face mask, or as a last resort, a surgical airway.
And this quote just sums it up perfectly. I'm going to read it because it is so important. It is failure to oxygenate patients rather than failure to intubate that ultimately leads to serious morbidity and mortality. That right there, that is the mindset you have to have during an airway crisis. Your job is to oxygenate.
All right, our final section, safety and human factors. This is where we zoom out from the technical skill of just one person, and we look at the team, the systems, and the communication that are what really keep patients safe.
The Arachnid acronym is a fantastic little tool to help you remember all the key parts of a safe airway system. It covers the whole shebang, from knowing your algorithms and using checklists, to those vital non-technical skills like communication and teamwork, all the way to how we design our systems and investigate when things go wrong.
And why is this so important? Well, just look at this. Data from the 4th National Audit Project shows that human factors, things like communication breakdowns or poor teamwork, can contribute to up to 40% of major airway complications. It proves that how we talk to each other is just as important as how well we use a laryngoscope.
So as we wrap this up, I'm going to leave you with this final thought. Look, mastering the technical skill of intubation is just the starting line. The real challenge, the true sign of a great anesthetist, is being able to answer this question. When it all hits the fan, can you lead the team? And that brings us to the end. All of this was based on the 2023 article Tracheal Intubation by McGuire and Hodge. I seriously recommend you read the full text to go even deeper. Good luck with all your revision.